Thank you, Rolando, and thank you, Minister and Associate Deputy Minister Barbara Wallman, for hanging around with us this morning. We really appreciate your support and your interest in the work of the Center. I have modified the slides, so if there are changes from what you have in front of you, I apologize, but there have been a couple of new developments over the last couple of weeks that I felt that I should include in my update. This is focused mostly on the retrovirus conference update. This took place February 23rd to the 26th in Seattle. And as usual, I thought I would bring you some of the news from Seattle and some of the stuff that happened since then in this brief summary. You have here my conflict of interest disclosure, my management and mitigation strategy, and I also added acknowledgements from various colleagues with whom I have shared materials, including slides and conference summaries, as you see here. So in brief, I'm going to talk about antiretroviral therapy-based chemoprophylaxis. I'm going to share with you some of the new results that came out at CROI, fairly impressive results, I must say. I will briefly talk about some of the newer antiretroviral therapy agents, mostly efficacy. I have, there is not a lot about safety really, and so I'm not going to dwell on that particular issue. These are experimental agents anyways. There was some new data regarding when to start, and there have been some developments since the conference, particularly with the release of the new DHHS guidelines in April, early April, about a week ago, in terms of what to start. And then I'm going to briefly tell you about my visit to Rome. I couldn't resist that. So let's go first for antiretroviral therapy chemoprophylaxis. As I said, I edited the slides and I grayed out some of the stuff that I'm not going to dwell on, and those changes are not on your handouts, so you have all of that information available. The first trial I wanted to mention is the so-called PROUD study. This looked at immediate versus deferred pre-exposure prophylaxis in high-risk MSM. This study was conducted in London, in the UK. It's a randomized open-label trial of daily oral tenofovir FTC or Truvada in MSM in various clinics in London. The patients were evaluated in two groups. One, the immediate PrEP group, 267 patients, and the other, the deferred group, where the PrEP was deferred for 12 months, approximately 250 patients, as you see here. The immediate PrEP was associated with an 86% risk reduction over 60 weeks. So it pretty much confirms what IPREX has shown among highly compliant patients. The 90% confidence intervals as shown there is 58 to 96%, again, in the range of what we've seen in IPREX. Interestingly, they provided us with the number needed to treat to prevent one HIV infection, and in this study, they needed to treat 13 patients to prevent one infection over a period of 1 year. The other study, which was rather different and innovative in its design, is the ANRS IPERGAY study. And this is the first time that on-demand oral PrEP is being assessed in high-risk MSM. I would take caution defining this group of individuals as being truly high risk, because if they use intermittent PrEP, as per the definition in this study, it means that they are not the highest risk individuals that we're familiar with in our program. This is a double-blind randomized controlled study of event-driven oral Truvada. There were 199 patients treated and 201 received placebo. The way that the scheme works roughly is that you're supposed to take 2 tablets immediately before the index sex encounter, somewhere in the 2 to 24 hours before that encounter. And then you take 1 tablet at 24 and 48 hours after the index sexual encounter. PrEP in this case was associated with an 86% reduction, the 95% confidence interval being 40% to 99%, Again, very consistent with the previous study, very consistent with the IPREX study. The number needed to treat for 1 year to prevent one infection, in this case, was 18, again, in the same range of what we saw in the previous UK study. The median number of pills taken per month in each arm was 16 pills. That gives you the sense that although these are potentially high-risk individuals, and the rate of infection certainly shows that, they are individuals that are having intermittent high-risk sex that allows them to take the pills for about 3 days and then goes period of time without taking the medications. You can call them the weekenders if you want to put it that way. The time to HIV infection is illustrated in the Kaplan-Meier curve that you see there on your left upper zone, and you see on the orange the placebo-treated individuals, and then the mitigation that is achieved by using Truvada, delay of infections, and certainly a much lower rate of infection. So that's for PrEP. Let's now move on to emerging antiretroviral therapies. These are new drugs. Perhaps the one area where there was the most interest was tenofovir alafenamide fumarate. That's the so-called TAF. TAF, as you know, is a prodrug of tenofovir and is being developed as a means to enhancing the efficacy of tenofovir, decreasing the exposure of target organs that may suffer side effects related to the tenofovir, kidney and bone in particular, and also it has the added feature that because the actual milligram dose is very small, this TAF will lend itself very well for fixed dose combinations moving forward. This is a parallel randomized double-blind active control phase 3 study. The primary endpoint is HIV RNA suppression at 48 weeks. The design is fairly straightforward. Individuals are randomized either to have TAF FTC albitegravir cobicistat or alternatively tenofovir FTC albitegravir cobicistat, the Gilead quad drug. And what you can see here is that virological success is in the order of 90% for both. Virological failure is 4% for both. And so for the most part, these two drugs are virologically equivalent, at least at this, with this limited number of patients treated. So TAF is, strictly speaking, methodologically speaking, non-inferior to tenofovir at week 48. The results were similar across all subgroups. There were 7 patients in the TAF arm and 5 patients in the TDF, tenofovir arm, that had nucleoside resistance at the viral failure. So again, fairly infrequent resistance emerging, as you are accustomed to see with Truvada-based therapy. And these continuations were very uncommon, 0.9% for TAF, 1.5% for tenofovir, consistent with what we know. Renal markers were evaluated for TAF and tenofovir, and I'm not going to go into the details, but if you look at the graph there, the changes in baseline GFR, estimated GFR, were significantly lower for TAF. There were basically smaller decreases in GFR and smaller changes in proteinuria, although not hugely different, but there is a movement in the right direction. With regards to bone mineral density, again, similarly to what we saw for the kidney, TAF is more benign. You see that in the blue line than tenofovir in the orange line. So altogether, pretty favorable. There is a new drug being developed. This is cabotegravir. This is a GSK drug. It's a dolutegravir analog. It has a long half-life. It's oral. Can be given in low dose again, so it lends itself well for fixed dose combinations, but in addition, is also being studied as an injectable formulation given even intermittently, which is something that is too early to tell, but it may be useful in specific populations if they were, for example, to be treated with one injection every month or every couple of weeks. For certain patient populations, that may be an interesting proposition. What you see here is the design of the study in the graphic form. They looked at cabotegravir at 10, 30, and 60 milligrams in the induction phase, and then on week 24, patients went on to the maintenance phase where rilpivirine was given. So cabotegravir plus rilpivirine alone as a novel sort of maintenance strategy. I think it's too early to start making judgments about that approach, but nonetheless, it's an interesting thing to look at in the future. The control arm for this study were 62 patients treated with efavirenz and 2 nucleosides, as you see in the continuous band in the yellow. The good news is that all arms in this study did quite reasonably well. The cabotegravir arm that did less well was the low dose cabotegravir 10 milligrams, but still it seemed to be fairly active. The 60 milligram arm had 84% suppression at the end of 96 weeks, so pretty impressive. The tripla-like or efavirenz-based treatment had 63% suppression. It's a bit disappointing. That's less than we're accustomed to see for a tripla. But that's what happens when a tripla is being handled by non-tripla friendly client or researchers. The next compound that I wanted to share with you is a second-generation maturation inhibitor. This is a BMS drug. You have the number there, 955176. This is a second-generation, once-daily drug that binds tightly and reversibly to HIV GAG. All doses beyond 10 milligrams were associated with significant declines in viral load, as you see here. The last 3 doses, 40, 80, and 120, had the most profound declines in viral load. The median change in viral load was 1.4 logs. So this makes it a very attractive and potent antiretroviral drug in doses, I would say, in the order of 40 to 120 milligrams once a day. There were no serious adverse effects, and there were no adverse effects-driven discontinuations. So at least in this short-term study, it seems that the drug did very well. As we've seen with other compounds, you see that patients were dosed for 10 days, and at least with the 3 more active drug doses, you see that it seems to be a lasting benefit in terms of viral suppression or time to viral rebound, and that's it may speak to the pharmacological or pharmacokinetic nature of the binding of the drug to the GAG target, suggesting that there may be some benefit in terms of forgiveness to incomplete adherence. I thought I'll add one slide regarding an issue that has been an ongoing concern regarding safety issues with antiretroviral therapy, in this case, abacavir and myocardial infarction risk. I'll ask you to concentrate on the red box, which basically gives you the punchline for the study that was presented here. This is from the HAART data. That's a long-standing collaboration of North American cohorts, including our own. And what they show is that the association between the recent exposure to abacavir and myocardial infarction risk diminish progressively after adjusting for additional cardiovascular disease factors, suggesting that there may be a confounding element between underlying cardiovascular risk and abacavir use. And the significant factors are illustrated here: age, hypertension, renal impairment, prior diagnosis of AIDS, and smoking and diabetes mellitus. So The suggestion here is that abacavir and MIs are probably an association, not causally related. Let me move now to the when and what to start. I'm sharing with you only new information. Perhaps the most important when to start study was the Temprano trial. This is again an ANRS French agency study. Temprano randomized patients in Côte d'Ivoire to a 2x2 factorial superiority trial, and the use for first line what is standard in that region, which include tenofovir plus FTC plus either efavirenz or Calitra or ACT. The inclusion of ACT there has been the source of some criticism, as you can imagine, because that's not a standard that is applied in the rest of the world. But subgroup analysis with or without ACT, I'm told, show the same results. There were 4 arms. The study looked at treatment initiation according to WHO criteria versus immediate 6 months INH prophylaxis plus treatment initiation according to WHO criteria, or immediate treatment initiation, that would be the early HAART group, or immediate 6 months INH plus immediate antiretroviral. So 2x2 factorial, INH prophylaxis, yes or no, and immediate versus WHO stage treatment initiation. Let's just move on to the yellow on the second column, and basically give you the punchline there. Early antiretroviral therapy was significantly associated with decreased morbidity overall, and when restricted to patients with baseline CD4 above 500, that was also associated with decreased morbidity. The risk of grade 3-4 morbidity did not differ between the strategies. So the bottom line is that this study confirms early initiation of antiretroviral therapy, decreases morbidity in the African context. INH adds to it, but antiretroviral therapy is an independent predictor of decreased morbidity if started earlier. That study, of course, as you can imagine, generated a lot of talk and a lot of restlessness regarding the wisdom of continuing the START trial, which, as you know, is another randomized study of immediate versus deferred therapy in people with high CD4 counts. My suspicion is that study is going to mature pretty soon, hopefully within the next year, and that controversy will be eliminated then. I felt compelled to bring to your attention the DHHS guidelines on the issue of what to start now, because they were updated really as I handed my slides to Kelly for this update. That was April the 8th of this year. And the recommendations pertain to initial combination regimens for antiretroviral therapy naive patients. What you have here is a significant change in the DHHS position. They are now recommending or favoring Truvada plus dolutegravir or elvitegravir, cobicistat, or raltegravir. Alternatively, within the recommended regimens, Kivexa dolutegravir, the fixed dose combination, triple therapy that VIV has, and then the final alternative in this case, Truvada with darunavir-ritonavir. The rest of the regimens have been classified as alternatives. That pertains to atazanavir-ritonavir, rilpivirine, and efavirenz with abacavir 3TC, which are alternative for people with baseline viral load of 100,000 or below. And then, interestingly enough, atazanavir-ritonavir and efavirenz, in the case of tripla, were classified as alternatives as well for all patient populations, largely as a result of the ACTG 5257 for the atazanavir-ritonavir, and largely due to issues of tolerability for efavirenz. This is not consistent with the direction that we're going. Now, of course, let's be clear, this is basically the box of what is acceptable for first-line therapy. In our case, we remain convinced that we need to turn this around and continue to recommend tripla and Truvada, atazanavir, ritonavir, the rilpivirine, efavirenz, abacavir 3-TC, and atazanavir, ritonavir, abacavir 3-TC combination for people with lower viral load, and only in exceptional circumstances, the dolutegravir, alvitegravir, raltegravir, and darunavir, ritonavir as first-line therapy. It's interesting that these recommendations don't take into consideration cost effectiveness first. Second, that when they talk about issues of tolerability, the marginal number of people that have tolerability issues with efavirenz is relatively small, and it really, in my opinion, it continues to be misguided to make a recommendation for everybody based on a small number of people that may have tolerability issues with efavirenz. They made the case that was necessary in their view because there was high level of suicidality in patients treated with efavirenz, which was in the single-digit percentage in one particular paper, when a separate meta-analysis published by the Journal of the International AIDS Society showed that there was no association with suicidality. So, in my opinion, that issue remains largely controversial. And at the end of the day, screening for efavirenz tolerability is actually quite simple. All you have to do is take the pill for the first week, and you'll know whether that patient is going to be happy with it or not. For the ACTG 5257, I deleted the slides, but I included them in your handout. Really, the situation is very similar. They knocked down atazanavir, ritonavir because of rather infrequent tolerability issues, bilirubinemia being the main one, and rare instances of renal issues being the second one. Virologically, though, all three arms perform exactly the same, so my contention continues to be the same. Given the cost-benefit of the atazanavir, ritonavir, and efavirenz-based strategies, given the options for salvage being so restricted, and the key role that dolutegravir, alvitegravir, raltegravir, and darunavir, ritonavir plays in salvage, we continue to support the status quo for our program. And this is not just me saying so. I modify here for brevity a statement that was put out by Francois Rafi, who is a good friend of us, even before he said this, from the University of Nantes in France. And basically he's saying before implementing dolutegravir as a first-line therapy, it's important to have more data and confidence regarding its high genetic barrier. We have today many first-line options with years of experience, and tolerability is a very important criterion when making choices. Dolutegravir can be associated with hypersensitivity when combined with abacavir 3-TC and with decreasing glomerular filtration rate, which can complicate renal monitoring when used with Truvada. In summary, advantages of dolutegravir are far from evident, and physicians should take a global view on published data and evidence before buying into this new drug, a very important player in salvage therapy. So all in all, I think Francois nicely summarizes our feeling in terms of where the DHHS guidelines are and vis-a-vis our own guidelines. Finally, I'll bring you up to speed on the 90-90-90 target, which, as you know, has now been formally embraced by UNAIDS as the proposed post-2015 Sustainable Development Goal for antiretroviral therapy globally. The objective of it being to maximize the effectiveness of existing tools by 2020 to virtually eliminate progression to AIDS, premature death, and HIV transmission, and thereby transform the HIV/AIDS epidemic into a low-level sporadic endemic disease by 2030, as highlighted by the Minister on his opening remarks. So the goal is that by 2020, we are proposing that 90% of people infected with HIV be diagnosed, 90% be on antiretroviral therapy, and 90% of those be virologically suppressed. I'm happy to tell you that as a result of the embracing of this strategy by the United Nations, Roche has negotiated a 90% cut in the viral load testing cost for South Africa that is being made now available to the rest of the low-income countries, a very welcome development. Stover et al. From the formerly Futures Group did some modeling for us in the context of the 90-90-90 development, and they were able to illustrate the potential impact that implementation of the 90-90-90 by 2020 and then carrying forward as 95-95-95 for to 2030 will have in terms of AIDS deaths on your left and new infections on your right. And as you can see, there would be a close to a 90% decrease in infections and death. These are only estimates, of course. All will depend on how well and how expeditiously the strategy is being implemented. And on that note, we had an opportunity to go up to the Vatican for the second time. The previous trip was about a year ago when we met with the Minister of Health, which unfortunately was ill at this time, and therefore we met with the Vice Minister of Health. That's the man on your left corner, up on the top. We met with the Minister of Justice and Peace on the right-hand side, on the left-hand side on the bottom, and then with the Pope's private secretary on the top here. He's an Argentinian, so he insisted that we get the picture taken in front of the map in the foyer of the Pope's office. And then, of course, I had the tremendous privilege of sharing a little bit of our work with the Pope himself, and as you all know, he gave us the thumbs up, which is something that I treasure for the rest of my life. So in short, I share with you some of the new evidence regarding PrEP, antiretroviral therapy, the new molecules that are being looked at, the issue that is more germane to our practice in terms of when to start, which basically validates our ongoing approach, and some of the emerging controversy around the DHHS reshuffling of the deck on first-line therapy. And finally, a brief update of our visit to Rome in the context of treatment prevention. Thank you very much for your attention, and I'll be happy to answer any questions or comments. Thanks.